All right, well, we'll go ahead and get started with today's last fellows presentation of the AMSSM ultrasound case series ultrasound presentations. I have the pleasure of introducing Dr. Doug Bryant. He completed his PM&R residency at Vanderbilt, where he served as chief resident, and he's currently finishing up his sports medicine fellowship at Penn and will be staying on at Penn for a PM&R sports medicine faculty position. And today he's going to be presenting on the topic of posterior ankle impingement.
All right. First just wanted to thank Dr. Schaff and all those that helped with these case series. These have been incredibly helpful during my residency and fellowship. So really excited to be presenting this case this morning. So this morning I'll be talking about posterior ankle impingement in a pediatric dancer. And I was fortunate to work with Dr. Naomi Brown over at CHOP on this and also had some help from Lauren Hipshin, my co-fellow. So starting off with some objectives, my objectives this morning are to present a case of posterior ankle impingement in a pediatric dancer, describe a diagnostic ultrasound protocol for evaluating posterior ankle impingement, and then finally review a diagnostic ultrasound report for posterior ankle impingement. So our case this morning is about a 14-year-old female dancer who presents with 3 years of posterior right ankle pain. The pain is worse with activity involving plantar flexion, especially going into the on point position, which for those not familiar with it, it's right here. So you can imagine kind of the pathology you might expect to see with that. And her pain is overall improved with relative rest. She does not have any mechanical symptoms or instability, no radicular pain, numbness, tingling, or weakness. She has previously tried icing the area, doing PT, and then taking some time off, but unfortunately her symptoms have not improved. And then on physical exam, really just notable for pain with full plantar flexion, but otherwise the rest of her physical exam is fairly unremarkable. And so before we get into the ultrasound protocol, I think it's important to think about clinically what might be going on here. So certainly in a pediatric dancer with posterior ankle pain, high on the differential is posterior ankle impingement, which there's a number of different things that can cause this, but os trigonum is up there for potential causes of that posterior ankle impingement in a pediatric dancer. Another thing to consider is FHL tendonitis or tendinopathy. Dancers really kind of rely on that FHL to kind of get that final push off to get into that on point position. So definitely can see that with higher frequency in your pediatric dancers as well. And then certainly with going to that plantar flexion position, considering things like Achilles tendonitis, plantaris tendonitis, tendinopathy, but also important to keep a broad differential outside of the musculoskeletal or the muscular injuries. So thinking about things like a osteochondral injury, a mass, a tumor, there's any enthesitis or inflammatory arthritis as well. And then diving into posterior ankle impingement a little bit more, this is a really great article there was a really great article in the World Journal of Orthopedics by Yasui and others from 2016 that really kind of describes a systematic approach to posterior ankle impingement and dividing potential etiologies into both the osseous lesions and then the soft tissue lesions. From the osseous side of things, we can see two kind of similar processes, the Steata process and the os trigonum as potential etiologies. You can also get osteophytes, osteochondral lesions, loose bodies, chondromatosis, and then subtalar coalition as potential etiologies of that posterior ankle impingement. And then from the soft tissue side of things, definitely considering the FHL, if there's synovitis, if there's an impingement of the joint capsule, as well as if there's any anomalous muscles, like if someone has an extra FHL muscle and tendon, that can certainly contribute to posterior ankle impingement as well. And then just a quick review of os trigonum. So really kind of its simplest form, it's an accessory ossicle at the posterior lateral talus. And you can kind of see this is a axial view, kind of looking down at the talus. You can see the os trigonum sitting here, just kind of posterior to the lateral tubercle. It is considered a normal anatomical variant that represents a failure of the fusion of the lateral tubercle and of the posterior process. It can be present in 20 to up to 30% of the population. And just its presence alone isn't necessarily pathologic. But when you do have pain that's caused by the os trigonum, it is called osteogonum syndrome, which is considered an overuse injury involving the osteogonum that's caused by repetitive plantar flexion. So that's oftentimes get that compressing into those structures I just went over, and can be very painful. So kind of with that clinical picture in mind, this is sort of the AMSSM sports ultrasound scanning protocol for the posterior ankle. And, critically thinking through what structures we really want to pay close attention to, definitely want to highlight the Achilles tendon and peritoneum, also including some dynamic scanning of the Achilles. In the pediatric population, less likely to have issues with the retrocalcaneal bursa or the retro Achilles or superficial bursas. But you're still in the neighborhood, so you can easily evaluate those. Also want to pay close attention to the plantaris tendon and then the posterior tibial-talar and subtalar joints as well. And then again, in the pediatric population, less likely to see kind of the issues with the plantar fascia and plantar fat pad, but again, you're in that neighborhood, can also scan those quickly as well. And then one other thing that we'll add on kind of from the medial protocol is really paying close attention to that flexor hallucis longus tendon and muscle. Again, like I mentioned earlier, it can really see pathology in that FHL and dancers because they really rely on it to get kind of that final plantar flexion push to get into that position. So kind of in summary, this is what we'll focus on for our protocol for the posterior impingement. For our protocol, I think easiest to have the patient lay in the prone position with the foot hanging off the table. Or you can also have the toes on the table with a pillow kind of underneath to prop it up. But you really want to allow for full ankle motion and toe motion, since that'll, one, kind of help you identify the certain kind of muscles and tendons, but also two, will help you dynamically evaluate these, especially since the posterior ankle impingement is a dynamic process. So you really want to pay close attention to that dynamic scanning. And then in terms of transducer, I think it's helpful to use a superficial transducer, but can also use a more general one too for the deeper structures. And we'll see that we kind of go back and forth between the two of these transducers. Starting off with the Achilles tendon and peritoneum, I think this is a really great home base because it's kind of easy to identify based on the surface anatomy. You can also palpate it for it easily. Here in the picture, you can just kind of see the Achilles tendon here. So a lot of structures can be described in relation to the Achilles tendon. So it really makes for a great home base when you're scanning and not sure what you're looking at. Just kind of find that Achilles tendon and go back to it and kind of remember where things are in relation to it. Starting off, looking at the Achilles tendon in long axis view. So this is kind of at the insertional portion here. We can see the Achilles tendon. You can see kind of the nice parallel fibular appearance of the tendons. That is normal, kind of coming in here. And you can see this is actually a good example of anisotropy with those tendon fibers kind of diving deep. You kind of lose their appearance and you kind of become darker. So it's important to not overcall this as a tear. So we can adjust kind of heel toe to get a better picture of that, and also using a gel standoff to kind of allow for that angle to get a better view of those insertional tendon fibers here. And while we're in this area, we can look for things like osteophytes, any enthesophytes. We can also turn on color Doppler to look for any microvascular changes that you might see in tendinitis or peritonitis as well. And then this picture is kind of, we're moving the probe more proximally, getting a view of the mid portion of the Achilles tendon, which again doesn't have as much vascular, so is susceptible to injury. We can see the Kager's fat pad kind of laying below this here. And then we're also kind of working up more proximally to the soleus here and the myotendinous junction as well. So important to evaluate all of those structures or all those components of the Achilles tendon here. And kind of in this view, you can also ask the patient to plantar flex and look for any obvious tears that you might see or any discontinuity of the Achilles tendon as well. Another thing that can be helpful too is comparing side to side. So if you have any questions or concerns for pathology, you can also just kind of compare the asymptomatic side to see if there's anything that's standing out comparing the two images. And then this is kind of a video where we're basically going along the same thing, but kind of going up more into the myotendinous junction, just kind of more fully evaluate that area more proximally. Again, you can ask the patient to plantar flex in any of these spots and kind of further evaluate dynamically any of these particular positions. And then also important to look in a short axis. Again, might see some discontinuity that you didn't see. And then also just confirm if you have any concern for any tearing. It's really important that you examine in two views. So here we're going to start the myotendinous portion. You can see here's the soleus below, the Achilles tendon here, here's the FHL. And we're going to work our way distally in the short axis view of the Achilles tendon. So here we are coming down. And then here is kind of that insertion on to the calcaneus there. So again, just important to kind of follow it along that whole kind of area in the posterior ankle to evaluate for any pathology. And then again, kind of less likely to be an issue in the pediatric population, but we're in the neighborhood, so pretty easy to look at these structures. So retrocalcaneal bursa kind of sits here, just kind of proximally from the calcaneus, and the retroachilles bursa kind of sits on top of it here. And here's a picture of kind of that where you'd expect to see that retrocalcaneal bursa. I will say you can have kind of physiologic fluid. So I think this is another one where comparing side to side can be helpful. You can also do sonopalpation to see if it's kind of painful to kind of press on that area. But again, it can have some physiologic fluid in there. So it doesn't necessarily mean it's pathologic. And then when you're looking at the retroachilles bursa, I think it's really important to have a good gel standoff because if you apply too much pressure, you can actually compress that bursa. But here we don't see any evidence of it, but this is kind of the neighborhood where it would live in. And then next we're going to move on to the plantaris muscle and tendon. This can be a little bit difficult to ultrasound because it has a pretty variable clinical course, and it's also absent in a fairly significant portion of the population. So this can be another one where it's important to compare side to side if you have any questions of pathology. But it can be difficult to kind of visualize. And so here we are looking at the long axis view of the plantaris tendon. So I think one thing that has been described to me is it's almost like a double train track appearance where you have kind of the one track being the Achilles tendon and then the track below it being the plantaris tendon. So it can kind of see that kind of analogy and help you identify the plantaris tendon. And what you'd be looking for here is any kind of focal areas of thickening, any areas that are darker concerning for tears. And then again, you can kind of compare that side to side if you have any concern for pathology. And then also, again, important to look in the short axis view. So here we're going to start proximally with medial on the left-hand side of the screen and work our way distally. Here we have the soleus muscle. Here is the gastroc. And then here's kind of that plantaris as well. So we'll kind of go there, and you can kind of see the plantaris kind of run in between, again, the soleus and the medial head of the gastroc, and then kind of the medial portion of Achilles. But again, the exact clinical course can be a little bit variable. It can also be variable where exactly the plantaris joins with the Achilles tendon. Sometimes that can happen more proximally, sometimes it can happen more distally, or it can remain separate the whole way down. So those kind of things can make it difficult to scan the plantaris. And then another important thing to look for is we can do some dynamic testing, asking the patient to plantar flex and just see if there's any abnormalities in kind of tracking or movement of that plantaris tendon, which looks like it's moving nicely here. But, you know, in patients that have perhaps some tenosynovitis may have it getting kind of stuck on that tendon and not moving kind of smoothly. Next, moving on to the posterior tibiotalar and subtalar joints. This is one where I think it's helpful to use kind of more that general probe, just because they are deeper structures. And then also a little bit challenging to visualize as well, because you have the Achilles tendon kind of over top, and it's kind of that thick tendinous material that makes it more difficult for the ultrasound waves to kind of pass through. So it can be challenging to get a good picture of these joints, but I think also having a good understanding of the bony anatomy can be helpful. So here's an MRI of basically the same kind of longitudinal view here of those joints. You can see on the right-hand side of the screen the calcaneus, the talus in the middle, and then the tibia on the left-hand side. So again, kind of corresponding to those bones that we see here on the long axis view of those joints. So kind of filling in based on our knowledge of the bony anatomy. So these kind of correlate to the tibio-talar joint here, and then the subtalar joint here as well. And so some important things to look for while we're in this view would be any effusion, any synovitis. And with the effusion, you might see some lifting of the FHL muscle here, as well as Kager's fat pad too. So there's important things to look for in this position. Can also look for any loose bodies. If the osteogonum is kind of migrated, kind of from that lateral position as well, might be able to kind of see it here. And then also important to look in short axis as well, like kind of looking for any lift off of Kager's fat pad, and then can also look for any osteogonum here as well. So here's kind of that tibia, which is going to fall away. We're going to get the talus here, and then we're going to get the calcaneus popping in up here. So again, just kind of looking for any osseous abnormalities, if there's any, osteogonum or any other loose bodies, you might be able to visualize it best in this view, because you're really kind of getting the full medial lateral view of those joints. And then next, we're going to move on to the FHL. So this also has some variability, which can make it difficult to scan. And also this variability kind of helps contribute to posterior ankle impingement. It's a little bit kind of outside of the scope of this talk, but there's variable ways to kind of measure how low laying the muscle belly is. But with ultrasound, the good thing is you can kind of see that muscle belly dynamically and see if there's anything impinging on it. So, qualitatively, we can say whether or not there's impingement, although ultrasound may not be the best to quantitatively kind of measure how low laying that FHL muscle belly is. And then typically, like I mentioned, it does pass medially to that os trigonum. So just a helpful kind of thing to consider when we're trying to find that os trigonum and where it lays with respect to the FHL tendon and muscle. So here is a long axis view of the FHL. We can see it here kind of over the tibia. So that's always kind of a good relation to remember, is the FHL kind of sits above that tibia and then below Kager's fat pad. And then can also kind of track more proximally and see kind of the intramuscular portion of the tendon and evaluate again for any pathology that we might see here, any focal swelling. And again, this is where kind of comparing side to side can be helpful as well. And then it's also helpful to do sort of dynamic testing. So here we're asking the patient to flex and extend their big toe and kind of evaluating for if this FHL kind of muscle belly getting caught on any osseous lesions, any synovium, or anything else that's kind of contributing to abnormal kind of movement there. So I think this is a really great kind of use of ultrasound to dynamically evaluate that FHL. And then this video, we're actually going to work kind of medially to kind of get to where the FHL tendon actually passes over the medial malleolus and then the talus down here. So we're going to work our way medially. Here's kind of that muscle belly. And then the medial malleolus is going to kind of pop into view here shortly there. And then there's the talus down there. And there we can kind of see the tendon kind of coming over here. And again, evaluating kind of in a different view of that tibio-talar joint to see if there's any kind of catching along the synovium or any other osseous process. And then also important to look in short axis. So here we can kind of see our home base with the Achilles tendon up here, the soleus, and then the FHL. And then we're going to work from that proximal position, kind of working down distally to track this FHL as it goes to the tarsal tunnel and kind of see where it rests on that talus. So here we have still muscle belly tendon, and then we're going to get to still muscle belly tendon. Sorry, other way around. And then here we can see more just kind of tendon sitting on that talus there. So again, this is kind of a nice way to qualitatively evaluate the FHL muscle belly and tendon and see if there's any abnormalities, if there's any bony structures that's getting compressed on. It is helpful to kind of evaluate in the short axis view as well. And then these are some images from our patient that have abnormal pathology. So sorry, this image, kind of the orientation is flipped. So we have distal on the left-hand side of the screen. But here we can see this is the os trigonum, and this is the FHL. This is in long axis view. And we can see the FHL actually comes down pretty far distally here next to that os trigonum. This is a short axis view, again, of the os trigonum sitting here and the FHL as well. That here's the talus. So you can kind of see there's still some muscle belly kind of around that FHL tendon. So I would say that this is qualitatively a lower laying FHL next to that os trigonum. But again, to kind of get those true measurements, it would be helpful to have kind of MRI imaging. And then this is a view long axis of that FHL tendon, kind of a little bit more distally from where we were before, kind of looking at the talus here. And in this video, we're asking the patient to plantar flex, and we're going to see the os trigonum kind of come in and actually kind of impinge on that FHL muscle belly. So here we go, and kind of coming in there and hitting the kind of muscle belly there. So again, this is a really nice way of using ultrasound to kind of ask the patient to do the provocative maneuver and correlate to any pathology that you see on ultrasound. And then just for completeness, so here's kind of the plantar fascia in long axis view, and then here's the transverse short axis view, kind of following it distally as well. Again, this is another one we're kind of evaluating side to side, can be helpful, evaluating for any enthesophytes, if there's any focal areas of thickness, but again, kind of less relevant for the posterior ankle impingement, but I think important to consider on your differential diagnosis, especially if the pain is kind of more in the plantar foot region as well. So this is kind of our ultrasound report. So, just kind of highlighting some of the key findings. So in that posterior tabular joint and subtalar joints, we did visualize the os trigonum with the FHL. We did visualize kind of the low-lying FHL muscle belly with impingement with the os trigonum with provocative plantar flexion. So in summary, our findings are that there is os trigonum with a low-lying FHL muscle belly near the os trigonum. There's also impingement with provocative plantar flexion. And because we've seen this patient clinically, we are able to give them the diagnosis of posterior ankle impingement due to os trigonum impinging the low-lying FHL muscle belly. And then, so just for the clinical course, we did also get an MRI of the right ankle, which did actually show the osteochondral lesion as well. And then also that os trigonum, which did have some edema and cystic changes too. Later on, the patient actually did have more kind of FHL tenosynovitis. So the patient did ultimately have an ultrasound-guided FHL tendon sheath injection, which did improve her symptoms temporarily. But ultimately, this patient did go on to need surgery. So did have that chondroplasty, as well as right ankle posterior debridement and excision of the os trigonum. And unfortunately, a lot of these posterior ankle impingement patients do ultimately end up needing surgery. I think one of the numbers in literature is 40%. So can be difficult to manage this non-operatively, unfortunately. And so big takeaways from this are that ultrasound is a helpful tool in the diagnosis of treatment of posterior ankle impingement due to os trigonum syndrome. Again, I think it's really helpful to use ultrasound dynamically. MRI can be great to get a good kind of static picture of what's going on, but ultrasound can be used to really dynamically see what's going on with the muscles and tendons and joints in that area. But it is important to consider additional advanced imaging to kind of evaluate for other pathologies, for instance, osteochondral lesions. And then also just another important thing is just the presence of ostrigonum in and of itself is not pathologic. But once you do get kind of overuse injury and pain, that's when it is kind of called the ostrigonum syndrome. And with that, thank you all for your attention. These are some pictures of my fellow, my co-fellow Lauren Hipschman and the CHOP fellows, as well as the surgical pen fellows as well. So it's been a great year. Hard to believe it's over. And yeah, that'll open it up to some questions.
All right. Well, thanks so much, Doug, for that thorough presentation. Just a couple comments before taking any additional questions, if anyone has any. I think you already kind of hit a lot of the highlights that, for this condition, obviously, ultrasound can play a huge role, just because it's going to be the only imaging modality that you can take a look at this dynamically. And then, of course, correlate it to the patient's symptoms, where everything else is going to be more static, imaging. So this really can be very useful in the workup of this condition, but obviously isn't going to be the end all be all. As you alluded to, there's a lot of osseous, pathology that can occur with this. So I think always helpful to use additional imaging such as X-ray, even to begin with, just to go ahead and take a look at this. But through the ultrasound protocol, once again, important to note, as you highlighted, in that is looking at the osseous structures. I know we don't always think about that all the time with ultrasound, just because it's better to look at the soft tissues, but just remembering that you can definitely see secondary signs of osseous pathology, especially at the tibio-talar joint as well as in the subtalar joint for these conditions. Pathology that you can see are going to be effusions, as well as then synovitis. And then in the pediatric population, especially, you can see those subtalar coalitions and then correlate it to the patient's area symptoms as well, too. So it's just important to remember, not always just looking, of course, at the soft tissue structures with the ultrasound, but remembering to evaluate all the osseous, joints in that area as well, too. One thing just for, pathology for the FHL for this condition, I think one thing that can sometimes be helpful is that when you're scanning, especially at that os trigonum, of course, the patients can have pain at that area, but usually then what can happen is that just distal to that area, you can start to get some tendon sheath distension and tenosynovitis, and that may actually occur a little bit distally, especially to that medial malleolus. So just remembering to continue to track that tendon down distally, even past the ankle into the foot. And sometimes, of course, that can be a secondary sign that that tendon is getting irritated and pathologic. So those are kind of the main comments that I would make for it, but open to any additional questions. All right. Well, Doug, I don't think I'm seeing anything else pop up in the chat or seeing anyone else that wants to make any other comments. So I think that will conclude today's presentation and the fellow presentations for the year. So really appreciate all the fellows being willing to volunteer. Always a very good, learning experience from these presentations. So thanks again to all of the sports medicine fellows for taking the time to do these presentations. We will be starting up the faculty presentations again in July, then through December. The setup is going to be a little bit different for next year, that we're just going to be doing one presentation a month. And typically that will be towards the end of the last Friday of the month. And then really just trying to cover a presentation for each of the different 6 body regions, that being the shoulder, elbow, wrist, hand, hip, knee, and then ankle and foot. So we'll start those again in the next month. But once again, thank you to all the sports ultrasound and sports medicine fellows for the presentations this year, and especially Doug, thanks for concluding it.
Absolutely. Thank you all so much for your attention, and hope you all have a good day.